Sherry Berger here, back this week for Holohan's Hot Topics. I'm here with Dr. Melissa Holohan. What's going on in the world of critical care, doctor?
Well, this week we're going to talk about the bacterial isolate susceptibility to empirically selected microbials in dogs with bacterial pneumonia. This is certainly a very common thing that we see in our hospitals, and it's very hard initially when we don't know what type of bacteria is causing the pneumonia to choose the most appropriate antibiotics. And so I think that this study, although retrospective, certainly hits home on areas that we need to evaluate closer. So bacterial pneumonia in general is an acquired inflammatory lung disease, and bacteria can colonize the lower airways, in particular the lungs, by way of inhalation, potentially aerosols that can cause damage and set up an environment for bacterial overgrowth. Aspiration is certainly, at least anecdotally, a very common way that we see pneumonia. And this is usually aspiration of the oral pharyngeal contents or gastroesophageal contents. And these are our patients that are presenting with a history of regurgitation or a history of vomiting for any number of reasons that could predispose them to getting pneumonia. It can be an extension of local disease, and it can also be spread through the hematogenous mechanism. And so this would be a patient potentially with sepsis that has spread to the lungs. An extension of local disease would be a patient with tracheitis or potentially a tracheal bacterial infection that goes down into the lower airways. So certainly many ways to get bacterial pneumonia. However, it is difficult to diagnose definitively, at least. Most of our diagnosis is based on presumptive history, again, history of vomiting or regurg, potentially history of a puppy being exposed to a kennel, or even an adult dog that's not Bordetella vaccinated that maybe was put in a kennel or grooming facility. Clinical signs that are applicable to pneumonia, physical exam findings, although they may be subtle at times, especially if we have early onset of pneumonia, and then thoracic radiographs. And thoracic radiographs are very helpful. However, as many note, that it does delay usually about 2 to 3 days behind clinical signs. And so you may have a patient that's showing clinical signs of aspiration pneumonia in your hospital, yet on the radiographs it's not very clear, if at all, yet. And so that lag time is not always helpful when we're trying to get a diagnosis. The definitive diagnosis or the confirmatory test is doing a trach wash, a BAL, or a pulmonary fine needle aspirate. And so these mechanisms, probably the most common used is the BAL or an endotracheal airway wash, where we're putting a small amount of sterile saline down into the airway. We're sucking that saline back up, hopefully with a good amount of mucus and bacteria, whatever's in the airway at that time. And then we're submitting those samples not only for cytology, but also for culture and sensitivity. And that's really where we're getting our final diagnosis. However, that mechanism of getting that test is usually in some ways can be very overwhelming if you're not doing it on a daily basis because it does cause an increased risk to the patient. And if done appropriately, the test, at least in dogs and now a recent study out in cats, you can get good results without putting your patient at a high risk. However, again, it's a test that's more commonly done in referral hospitals or tertiary hospitals or universities, and not usually done in the local practice. And so it's hard sometimes to get a definitive diagnosis knowing what we're dealing with. So it'd be useful up front to know what type of antibiotics we can use without having to put our patients through that, especially the first time around pneumonia, where we may have a very easy isolate to treat, or a patient that has Bordetella pneumonia. So looking at the treatment of bacterial pneumonia, typically we are adding antimicrobials on and supportive care for that patient. And obviously in an ideal world, we would want those antimicrobials to be based on culture and sensitivity. Again, though, for the reasons that I had just stated, it's not always easy to get that definitive diagnosis and to know exactly what bacteria we're dealing with. Although having the right antimicrobials for the right bacteria hastens the resolution of disease, a lot of empiric antibiotics has been called into question on many diseases lately in human and veterinary medicine. And that's because when we're using broad spectrum antibiotics, there has been studies to show that it increases the resistance to antibiotics overall. it may not be appropriate if we're just guessing on what antibiotics need to be used. And at least in human medicine, there's been further research to show that it not only increases morbidity, but also mortality and the length of hospitalization. And so because this hasn't been looked at in our veterinary population, this study set out to try to gain a little bit more insight into this particular answer. So no previous data has been done regarding the frequency and impact of inappropriate empiric prescriptions, particularly for bacterial pneumonia. So this was based on in vitro bacterial susceptibility testing in dogs with pneumonia. In this particular study, what they wanted to look at was determining the proportion of airway bacterial resistant isolates to empirically selected and recently administered antimicrobials. And I think that looking at the bacterial resistance, not only to the antibiotics selected, but also those antibiotics that may have been used over the past few weeks prior to maybe the second or third veterinarian seeing this patient, becomes very important, as that's most likely going to set up a bacterial resistance. And then looking at the dogs with bacterial pneumonia, they wanted to assess the impact of inappropriately used initial empiric antimicrobials. So if you had chosen the wrong antibiotic up front, did this affect the length of hospital stay, and did this affect survival to discharge in these patients? This was a retrospective study evaluated at a university veterinary teaching hospital, and they found 111 dogs total with a clinical diagnosis of bacterial pneumonia as well as an aerobic culture and sensitivity of the tracheal wash. And so these patients did have confirmatory tests to back up their diagnosis of bacterial pneumonia. 26% of these dogs had greater than one bacterial isolate resistant to empirically selected antimicrobials. That certainly hits home. That's almost one third of the dogs had resistance to a selected antibiotic. Dogs with a history of antimicrobial administration within the preceding 4 weeks, actually the resistance was even higher. At overall, about 57% had bacterial resistance to antimicrobials. When you break down this category in this study, they found that it was a little bit higher in those patients with community-acquired pneumonia, which makes sense. They're being exposed to a hospital setting or a clinic or a kennel where they got community-acquired pneumonia. In those patients, 65% had in vitro bacterial resistance to antimicrobials. And then in aspiration pneumonia, about 55%, and other causes of pneumonia, about 50%. There was no statistically significant association, however, between the bacterial resistance to the empirically selected antibiotics and the length of hospitalization or mortality. So although this has been shown in human medicine, it was not able to be reported in this particular study. So they concluded that airway sampling for bacterial culture and sensitivity may be helpful in guiding the antimicrobial therapy. There was a high proportion of in vitro airway bacterial resistance, and so this essentially is stating if we just chose ampicillin or amoxicillin, we may not be getting those other resistant bugs. And so not only are we not fully treating that patient, we're also setting up for failure in the future with the resistant bacteria forming. Recently administered antimicrobials should be avoided when selecting empirical treatment. I think that overall, if we're the second or third veterinarian seeing this patient and they're not getting better, we're usually going to choose another antibiotic. However, some people just feel like they have to keep that Clavamux on board because maybe it's doing something. And I think that this study supports that we definitely need to move away from whatever antibiotic is being used currently and choose another one completely. And although this was a retrospective study, I think further prospective studies are indicated, and the researchers do go on to state that it'd be helpful to have a standard practice in airway sampling and treatment. Airway sampling can sometimes be difficult. If you haven't done it routinely, you get a lot of oropharyngeal contaminants, which can confuse your treatment plan. And then also having some set or protocol treatment of those initial antibiotics to grab while we're waiting for a culture to come back would be very helpful, so that we're all doing essentially the same thing and not setting up for resistance when we're grabbing our biggest gun off the shelf to treat while we're waiting for that. And then stratification of disease severity. This study, although we're looking at bacterial pneumonia, 111 dogs, we don't know how severely affected some of those patients were versus some may have been more of an outpatient care. And so using an arterial blood gas to analyze those patients with pneumonia may help us to better stratify those patients into mild, moderate, severe disease severity, and we may show some differences in hospitalization and mortality in those patients if we were to choose inappropriate antibiotics up front. So I think that overall, in our hospital, we do see a lot of Clavamox resistance with patients that, as particularly dogs, with suspected kennel cough. However, those dogs usually have a lot of mycoplasma, and Clavamox in general doesn't get mycoplasma very well. So I think that's probably one of the most common areas where I see some resistance there, and we have to choose another antibiotic to put on board. If it's an adult dog, Baytril is an excellent choice. If it's a young dog, doxycycline or azithromycin are usually those two. So that's just one example of many, but I think that we need to make sure we're choosing appropriate antibiotics up front, and if at all possible, getting a bacterial culture so we can change our therapy or our course of therapy over the course of a few days once we get those results back. And so I think that de-escalation therapy is now becoming one of the mainstays in not only human medicine but veterinary medicine, where we may choose not the biggest gun we have in our cabinet, like imipenem or vancomycin, but one of those middle range medications until we know, okay, is the lower medication okay, then we would switch out to that. But de-escalation therapy is essentially where we're grabbing those bigger antibiotics that are definitely going to get those bugs. And then once we get the culture back, we step it down to potentially doxycycline or some other antibiotic, the lowest one on that spectrum that's effective. So I think that certainly there are more studies to be done in this area and more research. Once we get those answers, we may be able to have a more protocol-based antibiotic selection when we're looking at bacterial pneumonia. But certainly more research to be done. But that's all this week on Holohan's Hot Topics.